Hello everyone, welcome back. Today I'll be covering regarding a clavicle fracture. In this video, started off with an introduction, anatomy of the clavicle, fracture classification, history and physical examination, radiological investigation, and complication. As an introduction, clavicle fracture occurs around 2% to 10% of all fractures. The middle third of the clavicle is fractured in 69% of cases. The distal third is fractured in 28% of cases, and the proximal third is fractured in 3% of cases. Adapted by study by Robinson C.M. et al. 1998. Middle third of the clavicle fracture represents 95% of fractures seen in children. Clavicle fractures are seen commonly during childbirth due to delivery procedure. Anatomy of the clavicle. The clavicle is an S-shaped bone and is the only osseous link between the upper extremity and the trunk. The clavicle articulates distally with the acromyon at the acromyoclavicular joint and articulate proximally with the sternum at the sternoclavicular joint. This first picture shows the S-shaped bone of the clavicle and the only osseous link. The second picture shows the attachment of the ligament surrounding the area of clavicle. At the sternal region, we have an anterior sternoclavicular ligament. We have a costoclavicular ligament. At the distal end, we have the acromyoclavicular ligament that attach between the clavicle and acromyon. And there's also a coracoclavicular ligament that connects between the coracoid process and the clavicle. Due to its superficial subcutaneous location and the numerous ligamentous and muscular force applied to it, the clavicle is easily fractured. Because the midshaft of clavicle is the thinnest segment and does not contain ligamentous attachment, it is the most easily fractured location. Regarding fracture classification. Number 1, Allman classification system. Dividing the clavicle into 3 groups based on location. Group 1, fractures of the middle third or midshaft fractures, the most common. Group 2, fractures of the distal or lateral third. Group 3, fractures of the proximal or medial third. This picture shows the Allman classification system, whereby the group 1, the middle third, is the most commonly fractured, followed by group 2, and lastly group 3, at the middle 1/3, near the sternal attachment. Number 2, Neer classification. Type 1, minimal displacement. These fractures occur just lateral to the intact coracoclavicular ligament and managed non-surgically. Type 2, medial fragment is separated from the coracoclavicular complex. The fragment is displaced inferiorly due to the pull of the sternocleidomastoid muscle. The distal fragment is displaced cranially. Obvious deformity and there is a high rate of non-union. Type 3, non-displaced fracture but extend into the acromyoclavicular joint. Is treated conservatively. However, late acromyoclavicular degenerative changes can occur and may require excision of the distal clavicular segment. There's no picture regarding the Neer classification because you must remember there's also a modified Neer, and then after that it subdivide type 2 into 2A to B to C, and then type 3 to A, B and C, and so on. For history and physical examination, the commonest is fall onto the shoulder. Patient complain of well-localized pain at the fracture site. He or she may hear a snapping or cracking sound when injury occurs. For physical examination, there will be a visible or palpable deformity over the fracture site. Localized tenderness, crepitus, ecchymosis, or edema over the clavicle. Severe angulation or displacement of the fracture may result in tenting of the skin. High risk to develop open fracture. Because of the proximity of the brachial plexus and subclavian vessels to the clavicle, it is important to perform a complete neurovascular examination. If there is a decrease in distal pulses, discoloration, or edema may present a subclavian vessel injury. Brachial plexus injury may present with distal neurologic findings. Lung examination throughout pneumothorax or hemothorax. Patient presented with shortness of breath or diminished breath sound is a clue. Palpations of surrounding ribs and scapula throughout associated fracture. This figure illustrates the neurovascular surrounding or below the clavicle region, subclavian artery, vein, the suprascapular artery, nerve, the thoracoacromial artery, and lateral pectoral nerve are near the clavicle. For radiological evaluation, a standard anterior-posterior clavicle radiograph, a 45-degree cephalic tilt view, improve the assessment of the degree of clavicle displacement. CT scan to guide treatment for less frequent proximal or distal fractures to evaluate intra-articular involvement. An expiratory posterior anterior chest radiograph if there is concern for possible pneumothorax or rib injury. Concern for neurovascular injury, arteriography and CT scan may help. Guarding management. Absolute indication for surgery. Patient with neurovascular compromise, open fractures, tenting of the skin, severe angulation or displacement, or any break in the skin near the fracture. Relative indication for surgery. Near type 2 displaced distorted fractures, fracture shortening more than 1.5 cm or 15% of the contralateral side, floating shoulder, polytrauma patient, seizure or neuromuscular disorder patient, cosmetic tissue due to displacement of fracture. Complications of clavicle fracture. 1. Most common is malunion, or when the fracture heals with angulation, shortening, or a poor cosmetic appearance. In patients with continued pain, decreased range of movement, or decreased strength secondary to the malunion, delayed surgical correction may be required. Number 2, non-union, especially for distorted clavicle fracture. Risk for non-union: advanced age, female, smoking, significant displacement or shortening of the fracture, fracture comminution, and inadequate immobilization. Number 3, post-traumatic arthritis, especially in proximal third clavicle fracture. Number 4, acute complication. Proximal clavicle fracture can displace inwardly, may result in severe intrathoracic injuries, including brachial plexus injury, subclavian vessel injury, and pneumothorax. Yay, we have reached to the end of this video. See you in the next one. Take care and bye.